I'm Dr. Ujjwala. I work as a mentor in StudyMEDIC, and today I'll be discussing few topics from benign gynecology, including genitourinary fistulas, benign breast disorder, and female sexual dysfunctions. So I would like to start with a saying, you are going to make it. It will be hard, but you are going to make it. That reminds us that we can overcome the circumstances. So let's begin with our first topic, that is a genitourinary fistulas. We will see some SBAs and EMQs. Eva, a 32-year-old multiparous woman present with a constant leak of urine per vagina. That started 3 weeks ago. She had a prolonged obstructed labor at home lasting over 30 hours and eventually underwent an emergency cesarean section in a rural hospital. The neonate was stillborn. Since then, she has experienced continuously urinary leakage without urgency, dysuria, or awareness of the bladder filling. She feels wet all the time, requiring frequent pad changes, and is now socially withdrawn and distressed. On examination, her external genitalia appears normal. Speculum examination reveals clear fluid pulling in the vaginal vault. A methylene blue dye test shows the blue stent fluid is seen leaking through the anterior vaginal wall, and a 1.5 centimeter defect is noted in the anterior fornix of the vagina. The question is, what is the most likely diagnosis? And the options are given here. The correct answer is vesicovaginal fistula because the patient presents with the continuous involuntary leakage of urine through vagina following a difficult, prolonged obstructed labor. On examination, fistulous opening on the anterior wall is seen, vaginal wall is seen, which is typical site of communication between the urinary bladder and the vagina. And this VVF is result from ischemic necrosis due to the prolonged pressure of the fetal head causing due to the obstructed labor leading to abnormal tract between the bladder and the vagina. And this explains the continuous dribbling of the urine that the patient is unable to control. Why it is not the other differentials, that is a uretrovaginal fistula? Usually it is seen post-hysterectomy and urine not stained with dye. Urethrovaginal fistula is common after prolonged catheterization or trauma. In stress urinary incontinence, typically present with the leakage only on exertion, not continuous dribbling. In urge incontinence, present with urgency, patient present with the urgency frequency and which are absent here. These are the different types of the genitourinary fistulas. I have taken this slide for your reference. You can go through it. Coming to the next SBA, Emma, 38-year-old woman, underwent total abdominal hysterectomy for fibroids 10 days ago. She now reports a persistent watery vaginal discharge that started 3 days after the surgery. She is able to void normally and does not report urinary urgency, frequency, or dysuria. However, she feels always wet, and this has affected her quality of life. On pelvic examination, clear fluid is noted in the vagina, but no obvious fistula is visualized. A 3-swab dye test is negative. None of the swabs are stained with dye. A positive void residual is minimal. A cystoscopy shows both ureteric orifice and no bladder defect. CT urogram is requested. The question is, what is the most likely diagnosis? And the options are given here. The answer is uretrovaginal fistula, which is continuous vaginal leakage with normal voiding pattern, suggests the urine bypassing the bladder. There is a negative dye test, rule out vesicovaginal fistula. Cystoscopy shows normal bladder and ureteric orifices support the diagnosis. CT urogram or IBP confirms uretrovaginal communications. Why it is not OAB? Because there is no urgency frequency. Here the discharge is continuous, not episodic. In overflow, why it is not overflow incontinence? As there is a minimal post-void residual and gallbladder empty. In stress urinary continence, the exertions of leakage is not related to the exertion. Here, there is a continuous watery discharge, but in urinary continence, the leakage is always related to the exertion. Here, in ureterovaginal fistula, the incontinence is incomplete, and you will locate it that the fistula is always small and high up in vagina, lateral to the cervix. Coming to the next SPA, Ola, 43-year-old woman present to the gynecology outpatient clinics with complaints of continuous leakage of clear watery fluid per vagina for the past 10 days. She underwent an abdominal hysterectomy 2 weeks ago for symptomatic fibroids. The surgery was described as challenges due to dense adhesions around the bladder. Since the surgery, she has been using a multiple pads daily and reports that the leakage continues day and night. Although she is still able to void normally, she denies any urgency, dysuria, or hematuria. There is no offensive odor. Speculum examination reveals clear fluid pulling into the vaginal wall, trickling from the anterior vaginal wall. 3 swab dye test with methylene blue is performed, suggesting a vesicovaginal fistula. You decide to proceed with the confirmatory investigation to define the location and the size of the fistula and to check the relation to the ureteric orifice before planning the surgical management. The question is, what is the most appropriate next step to confirm the diagnosis? These are the options. So here, as we diagnose the VVFs, the gold standard confirmatory test is cystourethropy. It allows direct visualization of the fistulous tract, assessment of its size, and evaluation of the ureteric orifice, which is crucial before any surgical repair. The 3 swab test and the other dye test are useful screening tools but not definitive. IVP and CT urograms are better suited to diagnose ureterovaginal fistula, not first line of VVF. Coming to the EMQs, these are the options provided and we have to choose here the most appropriate options. Scenario 1, Sarah, 36-year-old woman, present 8 weeks after an abdominal hysterectomy for fibroids. She complains of continuous leakage of clear fluid per vagina that begins a few days after her surgery. A dye test confirms the presence of a single vesicovaginal fistula measuring 2 centimeters in diameter, located at the middle vagina, just above the trigone. Vaginal examination shows pliable and healthy tissue. Imaging and cystoscopy rule out any ureteric injury. Here the question asked is which is the most appropriate surgical approach for the repairing her fistula? Answer is a transvaginal approach for small to moderate size mid-vaginal fistulas in accessible locations with healthy tissue and no ureteric involvement. The transvaginal route is preferred due to reduced morbidity and quicker recovery. The other routes of repair of the bladder fistulas are transperitoneal for vesicouterine fistula, transvesical approach when the fistula are not visualized for vagina. In addition, transperitoneal or transvesical approach is preferred when the fistula margin are close to the ureteric orifices. Another scenario, Noah, 41-year-old woman, has undergone a planned transvaginal VBF repair. The surgery was uncomplicated and the repair was anatomically successful. She is keen to understand how she can reduce the chance of the recurrence. Which of the following is an essential factor for ensuring successful long-term closure of the fistula? The correct answer is good tissue vascularity. The most important factor for successful fistula repair is ensuring the tissue edges are well vascularized. This promotes healing and reduces the risk of the breakdown. These are the criteria for the successful repair. If the fistula is single, VVF, and less than 4 centimeter, that's indicate good prognosis. If it is multiple, mixed, and more than 4 centimeter, it shows the uncertain prognosis. If the urethral involvement and vaginal scarring are absent, that is an indication of the favorable prognosis. But if it is present, it shows uncertain, it gives the uncertain prognosis. Tissue loss, if it is minimal or ureters draining inside the bladder, it gives the good prognosis. While as if it is a tissue loss is extensive and ureters draining into the vagina, there is an uncertain prognosis. Coming to the another scenario, Sarah, a 52-year-old woman, underwent a transabdominal repair of a large vesicovaginal fistula using the O-corner technique. The surgery involved careful multi-layer closure and interposition of a peritoneal flap. She is now in the recovery room. Her vital signs are stable and there is no intraoperative ureteric damage. The question here is, which of the following is a critical component of her immediate post-operative care to optimize fistula healing? The answer is adequate bladder drainage for 10 to 14 days, which is a vital post-operatively to reduce tension on the repair site and which facilitate healing. Along with urinary antiseptics and antibiotics should be provided. Avoid sexual intercourse for 3 months. Avoid pregnancy for 1 year. And cesarean section is almost absolutely indicated. Coming to our next topic, that is a benign breast disorder. Here, the first SBA is Mrs. Julia Morgan, 42-year, present with a painless lump in her left breast. Notice 3 months ago, the lump is unchanged in size with no nipple discharge, skin changes or pain. She has no personal or family history of breast cancer. On examination, 3 centimeters soft, well circumscribed mobile lump in the upper outer quadrant of the left breast. No skin dimpling, nipple retraction or axillary lymphadenopathy. Contralateral breast are normal. Here the question is, what is the most likely diagnosis, and the options are given here. The correct answer is the breast lipo. It is a benign tumor of adipose tissue, usually subcutaneous, slowly enlarging and painless. Most commonly occur in women 40 to 60 years. Clinically, it's appear very soft, feels like a fat, well circumscribed, mobile within the breast tissue, typically painless, usually single, though multiple lipomas can occur. No skin or nipple changes and axillary lymph nodes are usually normal. How it will be differentiated from the other differential diagnosis? Fibroadenomas, you will see it in the younger women less than 35 years. They are firm, rubbery, mobile, and well circumscribed. Usually less than 3 centimeter, may grow with hormonal changes. While in fibrocystic changes, there are multiple lumps, often tender, fluctuate with menstrual cycle, often bilateral, cystic on ultrasound. In breast carcinoma, the lumps are usually hard, irregular, fixed, and painless, and there are some nipple and skin changes, often solitary associated with the lymphadenopathy. In phyllodes tumor, they are rare, rapidly growing form, may be large, and require surgical excision for the diagnosis. Whenever the patient comes with the breast lump, always go in a stepwise manner. This is the chart I have taken it for the reference. You can go through it. My next question is Emma, 48-year-old woman present to the breast clinic with a firm irregular lump in the upper outer quadrant of her right breast. She first noticed it 3 weeks ago. The lump is non-tender and not associated with nipple discharge. She has a history of seat belt injury following a road traffic accident 2 months ago. There is no family history of breast cancer. On examination, the lump is fixed to the surrounding tissue, but not to the skin or the chest wall. There is no axillary lymphadenopathy. Mammography shows speculated lesions with area of calcification, and ultrasound reveals an irregular hypoechoic area. Fine needle aspiration cytology is inconclusive, but core biopsy demonstrated foamy macrophages and fat-filled cystic spaces with inflammatory cells. Here, the question is, what is the most likely diagnosis? And the options, these are the options. The correct answer is the fat necrosis because it's a benign inflammatory process caused by the trauma, surgery, or radiation. And it can mimic breast carcinoma, both clinically hard, irregular lump and radiologically speculated lesions calcification are seen. The key differentiation from carcinoma here is there is a history of trauma, benign histology, and lack of the malignant cells. The third SPA, Lena, 34-year-old woman, present to your breast clinic with a 6-month history of bilateral breast pain and lumpiness. She reports that the pain is worst in the week before her periods and improve after menstruation. There is no nipple discharge, no family history of breast cancer. On examination, both breasts feel nodular with no discrete dominant lump or axillary lymphadenopathy. Ultrasound shows diffuse fibroglandular changes with no suspicious lesions and BIRATs too. Which of the following is the most appropriate initial management? The options are given here. Here, as it shows a fibroadenosis, also called as a fibrocystic changes, which is a benign, hormonally mediated condition characterized by the breast pain, nodularity, and cyclic symptoms fluctuation. So it is most common in women 30 to 50 years of age, and symptoms often resolve after the menopause. So the correct answer, the symptomatic treatment here is the supportive bra, evening primrose oil, NSAID, and reassurance about the benign nature. So the correct answer is reassurance and the symptomatic treatment. Now we'll start EMQs. These are the options provided, and here we have to choose the most appropriate diagnosis or the management option. Scenario 1, Lena, a 22-year-old woman, present to the breast clinic after noticing a lump in her left breast during self-examination around 4 weeks ago. She is otherwise fit and well, with no family history of breast cancer and no significant past medicals. She has no nipple discharge or skin changes. The lump has not increased in size and is not painful. On clinical examination, the lump is approximately 2.5 centimeter in diameter, located in the upper outer quadrant, well defined and feels smooth, firm, and well circumscribed, and highly mobile under the skin. There is no axillary lymphadenopathy. Ultrasound finding shows homogeneous oval hypoechoic lesions with smooth margins. Classification by RADS2 by the radiology. If the lesion is confirmed to be fibroadenoma, what is the most appropriate management? The most appropriate management is the routine surveillance and reassurance, as a fibroadenomas are the most common benign breast lesion in the young woman aged less than 30, and they are typically present as a painless, highly mobile, rubbery, well-defined lump, often described as a breast mouse. And the ultrasound in the young woman, which shows the homogeneous hypoechoic lesions with regular margin, that is a BIRAT 2, is always, if typical and less than 3 centimeter, then often require no further intervention besides observations and follow-up. Core needle biopsy may be done if diagnosis is uncertain or there is a family history of breast cancer. Indications for the surgery, if the fibroadenomas are more than 3 centimeter, there are multiple giant recurrence for the cosmesis and the complex type. Scenario 2, there is Olivia, a 33-year-old woman, 3 weeks postpartum, present to the emergency department with a 3 days history of increasing pain and swelling in her left breast. She is currently breastfeeding. She reports localized tenderness, fever 38.7 degrees centigrade, fatigue, redness of the overlying skin, difficulty breastfeeding from the affected side due to the pain. On examination, the left breast is solar erythematous. There is 4 centimeter fluctuant tender area in the upper inner quadrant and no nipple discharge. Ultrasound shows hypoechoic collection with the internal echoes consistent with the localized fluid collection. What is the question is, what is the most likely diagnosis in this case? So the diagnosis is the breast abscess. which is a common complication of infective mastitis and particularly in the lactating women. And it typically presents with a fever and symptomatic symptoms, localized pain, swelling and redness, a fluctuant mass suggestive of first collection. Ultrasound confirms the presence of the fluid cavity in this case, and which is strongly suggestive of an abscess. So breast abscess is the most likely diagnosis where the first line management is ultrasound guided needle aspiration combined with antibiotic therapy, usually fluoxetine or clindamycin if penicillin allergic, and incision and drainage are reserved for the large or multiloculated or recurrent abscess. Breastfeeding should be continued from the affected area and encouraged on the affected site if tolerated. Scenario 3, Hana, 43-year-old multiparous woman present with a 3-month history of sticky greenish nipple discharge from both breasts, more pronounced on the left side. She denies pain but reports some discomfort behind the nipple. There is no history of trauma, fever, or palpable lump. Menstrual cycles are regular and she is not on hormone replacement therapy. On breast examination, slightly nipple retractions is noted, no palpable mass, mild tenderness beneath the areola. Mammogram shows ductal dilatations, no suspicious mass or calcification. Cytology of nipple discharge is benign. The question here is, what is the most likely diagnosis in this woman? The diagnosis is the mammary duct ectasia, which is usually affect the perimenopausal or menopausal women. It results from ductal dilatation and inflammations of subareolar duct. Presentation include green or brown nipple discharge and nipple retraction, and sometimes subareolar tenderness. It can mimic carcinoma, but imaging is usually benign, and discharge cytology typically non-malignant. So treatment is usually conservative unless symptoms are persistent, in which case total duct excision may be considered. This slide is for your reference and for your last minute revisions will help you for your exam. Coming to our third topic, that is a female sexual dysfunction. We'll see few SPAs and EMQs in this topic. Mrs. Hannah Lewis, a 27-year-old woman, attended the gynecological clinic with 11-month history of pain during intercourse. She describes the pain as a burning and stinging occurring at the moment of penetration and sometime when inserting tampons. She denies pain at rest. She has no abnormal discharge or urinary symptoms. Her past medical history is unremarkable. On examination, the vulva skin appeared normal. Cotton swab testing reproduced her pain when gently applied to the vestibule at the 5 and 7 o'clock position. High vaginal swab and microscopy are negative. So question is, what is the most likely diagnosis? And these are the options. Here the correct options answer is provoked vestibulodynia. The vulvodynia result always says when there is a chronic vulval pain more than 3 months with no visible abnormality or infection. It is provoked because there is a localized pain at the vestibule triggered by touch or the penetration. Why it is not candida? Because there is no history of erythema, discharge, or microscopy positive for candida. In genitourinary syndrome of menopause, which is usually seen in the postmenopausal women, and the vaginal mucosa are usually pale and dry. In herpes, you will see vesicles and ulcers. In lichen sclerosis, that would be atrophic changes. This chart helps you to differentiate the provoked from unprovoked vulvodynia. Coming to the next SPA, that is Emily John, 26-year-old newly married woman, report that she has been unable to have penetrative intercourse despite multiple attempts. She experienced involuntary tightening of the vaginal muscle and intense anxiety when penetration is attempted, making it impossible. She has never had a speculum examination. She denies any history of trauma, sexual abuse, or pelvic pain outside the intercourse attempts. So here the question is, what is the most appropriate first line management and the options are given here. So this is the case of vaginismus, where you are seeing here there is an involuntary pelvic floor muscle spasm preventing penetration. So first line treatment is gradual desensitization with vaginal dilators and pelvic floor physiotherapy. Hymenectomy not indicate because the problem is muscular, not anatomical. Topical estrogen for the genital urinary syndrome menopause related pain. CBD alone will not be that effective, but if it is given combined with the physical and the psychological therapy, it is more effective. Hysteroscopy unnecessary unless intrauterine pathology is suspected. My third coming to a third SPA, Miss Emily Carter, a 29-year-old woman present to a postnatal clinic 8 weeks after delivering her first child through spontaneous vaginal delivery. Labor was prolonged and she required a mediolateral episiotomy for instrumental delivery with ventouse. She reports that since resuming sexual activity at 6 weeks postpartum, intercourse has been painful at the point of penetration, making her anxious about intimacy. She described the pain is sharp and localized to the vaginal opening, especially on the initial penetration, but easing slightly once the intercourse continues. She has no vaginal discharge, fever, or urinary symptoms on pelvic pain outside of intercourse. She is breastfeeding exclusively. On examination, her episiotomy scar is well healed but slightly tender to touch. There is no erythema, swelling, or sign of infections. The vaginal mucosa appears slightly dry. Here, the question asked is what is the most likely cause of her dyspareunia? And these are the options. The most likely cause of her dyspareunia is episiotomy scar tenderness with lactational atrophy. In the postpartum period, especially during the breastfeeding, low estrogen level cause vaginal dryness, and which can aggravate the scar tenderness from an episiotomy. The pain is superficial, localized to the scar, and occur during initial penetration. Here, why it is not vulvodynia, because it is a chronic pain without clear trauma history and usually not so soon postpartum. In genitourinary syndrome menopause, there is a post which usually seen in the postmenopausal women due to the estrogen deficiency. In candidiasis, you will see the discharge, itching, and erythema. Vaginismus, there will be involuntary muscle spasm, often preventing penetration altogether. So the management here is usually reassurance, lubricant, provide her lubricant, pelvic floor physiotherapy, and topical estrogen if dryness is significant. Next, SPA. Mrs. Linda Brooke, a 58-year-old woman present with a progressive vaginal dryness, itching, and superficial pain during intercourse for the last 2 years. She went through menopause at age 53 and has not taken hormone therapy. She denies urinary urgency or incontinence. She is otherwise healthy and does not take any regular medication. On examination, the vulval skin appeared pale and thin with loss of normal rugae in the vagina. Vaginal pH is elevated. There are no ulceration, lesions, or sign of infection. She would prefer to avoid systemic hormone replacement therapy if possible. The question is, what is the most appropriate initial management? And the options are given here. The answer is, as it is a genitourinary syndrome of menopause and is due to the estrogen deficiency, where there is atrophy, dryness, and superficial dyspareunia. So first line treatment is non-hormonal lubricant and moisturizer. Systemic estrogen can be given if it is multiple or severe menopausal symptoms. Vaginal laser is limited evidence, not for the first line. Testosterone when there is a hyposexual desire disorder in postmenopausal women unresponsive to the estrogen. CBD for the psychogenic disorder, not for the GSM. Now come to the EMQs. These are the options and we need to choose the Single most likely diagnosis from the scenario. Scenario 1, Mrs. Sarah Mitchell, 37-year-old woman, gravida to para 2, attend the postnatal clinic 6 weeks after delivering her second child through normal vaginal delivery. She reports that her husband recently wanted to resume sexual activity. Although she agreed, she says she did not feel like having sex and experienced significant discomfort during intercourse. So they had to stop. She described the experience as very painful and frustrating. She is currently breastfeeding and has noticed vaginal dryness since delivery. She also reports feeling less interested in sex than before pregnancy, though she has no history of sexual problem prior to this pregnancy. She sleeps poorly due to caring for the newborn and feels somewhat fatigued. She has no mood disorder, no history of sexual trauma, and no chronic medical conditions. She is concerned about the impact of this problem on her relationship and asks for advice. On examination, perineal healing is complete and there are no signs of infection. Vaginal mucosa appears slightly pale and atrophic. Here, the diagnosis is the combined pain and desire disorder because the pain component is there, which is from she is 6 weeks postpartum breastfeeding, which leads to the hypoestrogenic states, causing the vaginal dryness and atrophy and lead to dyspareunia. Desire component, there is a history of fatigue, sleep deprivation, and discomfort during sex, reduce the sexual desire. Why not the other component? It's not purely desire disorder because there is a significant pain. Not an arousal disorder as she became aroused with the masturbation and and physiological response is intact. Not vaginismus as there is a no involuntary spasm. Pain is due to the dryness. So first line treatment is the non-hormonal vaginal lubricant for intercourse and vaginal moisture for the ongoing hydration. This I have taken from the talk. You can just go through it. Scenario 2 is a Mrs. Janet Williams, a 52-year-old woman, 2 year post-menopausal, present with ongoing difficulty enjoying sexual activity. She says she still has a sexual desire and can become mentally excited, but physically she feels nothing happens down there. She reports dryness, burning, and mild discomfort during intercourse despite foreplay. Her relationship is stable and she has no mood disorder. She is not on medication and has no chronic illnesses. Examination reveals mild vaginal atrophy with reduced elasticity and speculum examination is well tolerated. She has no vasomotor symptom and has not used HRT before. This is a diagnosis of an arousal disorder. Here, it is due to it's likely secondary to the postmenopausal vaginal atrophy, where there is a inability to achieve adequate genital lubrication. She has a desire, but she has a desire intact that rules out hyperactive sexual desire disorder. It is not an orgasmic disorder, not vaginismus. So here it is due to the postmenopausal condition and which is postmenopausal estrogen deficiency is the most common of this arousal disorder in this age group. So local vaginal estrogen therapy is the first line of treatment. Psychosexual factors should be considered if no physical cause is found. My third scenario is Mrs. Sophia Reed, a 35-year-old woman, has been in a happy relationship for 10 years. She describes normal desire and arousal but says, I just can't reach orgasm anymore. This has been present for the past 6 months. Before that, she had no problems achieving orgasm with intercourse or masturbation. She has no pain, no dryness, and no changes in relationship dynamic. She recently started on SSRI for anxiety 6 months ago. She has otherwise improved her mood. Pelvic examination is normal. She is embarrassed and frustrated, worried her partner will think she is no longer attracted to him. So this is a diagnosis of a female orgasmic disorder. where there is a persistent or recurrent difficulty achieving orgasm after adequate sexual arousal, causing distress, and it's lasting more than 6 months. This condition is due to the SSRI induced sexual dysfunction, where there is a frequently delay or inhibit orgasm due to the serotonin mediated inhibition of the spinal reflexes involved in orgasm. So, the here, management is consider switching to a different antidepressant or dose adjustment and offers psychosexual support. The last scenario is Mrs. Emily Carter, a 27-year-old woman present 8 months after her wedding. She and her husband have been unable to have penetrative intercourse since marriage. She feels intense anxiety and involuntary tightening of her pelvic muscles during any attempt, making penetration impossible. This happened even during the attempted tampon insertion and on gynecological examination. There is no history of sexual assault, pelvic inflammatory disease, or chronic pelvic pain. She has otherwise normal libido, no relationship conflict. She has tried using lubricant without improvement. So here the diagnosis is the penetration disorder vaginismus, which is involuntary tightening. There is an involuntary tightening of the pelvic floor muscles whenever the vaginal penetration is attempted, and she wants to here there is a normal desire and arousal as she wants to engage in sexual activity. She has normal libido, but the problem is the physical muscle spasm and anticipatory anxiety during penetration attempts. So the management here is the education and reassurance, pelvic floor physiotherapy, graduated vaginal dilator therapy, and cognitive behavioral therapy or sex therapy. This is the chart will help you for the last minute revision. You can just go through it. It's for your reference. So thank you for listening, and I hope this will help for your exam. Thank you once again.